Hi, I'm Dan Resnichek from Pacific Northwest Urology, and today we're going to be talking about aromatase inhibitors. Sometimes these are referred to as estrogen blockers. We're going to be discussing their use in men who are on testosterone replacement therapy. There's a lot of misinformation online and other YouTube videos out there claiming the benefits of these drugs. Often, muscle building bros talk about balancing your estrogen or optimizing your estrogen levels. And we're going to find out later that these are medications are associated with erectile dysfunction and decreased libido. I ask them, why are you on these medications? They tell me they want to normalize or balance their estrogen levels. They want me to check an estrogen level if they're on testosterone replacement therapy just to make sure that it's within normal range. These are men who are otherwise doing well overall. They just want to make sure they're not getting too much estrogen. So, unlike other videos that just give opinions on these medications, I'm going to review the science that actually is behind these medications and show you clinical trials that tested these drugs on men. I'm going to show you how other studies are expanding our knowledge about the physiology of estrogen in men. And we find that this hormone is essential to many tissues within the male body. We're then going to review the studies on the use of aromatase inhibitors. These studies will demonstrate clearly that these medications, while on testosterone therapy, has been shown to cause a host of medical problems from decreased bone mineral density to low libido and erectile dysfunction. That's right, it sounds crazy, but the hormone estrogen is essential for male libido and erectile function. Even just a slightly lower level of estrogen can cause a problem. First of all, let's review the basic physiology of estrogen in males. Where does estrogen come from? In men, most of the estrogen actually comes from the conversion of testosterone to estrogen. A small portion of estrogen comes directly from the testicle itself, or about 20%. But for testosterone, in addition to the effects on the body by itself, testosterone is a prohormone, which means that some of the effects of testosterone are mediated by other hormones that the molecule is then converted into within other cells. For testosterone, some of the circulating amount gets converted into estradiol or estrogen, and another portion gets converted to DHT, dihydrogen testosterone. The conversion to estrogen is done by a protein called aromatase. Studies have shown that the percentage of testosterone converted to estrogen, or a ratio, is consistent within men. So the amount of estrogen circulating in the body has a relationship to testosterone. So if you increase testosterone levels for men on low testosterone, their estrogen will also increase at a similar ratio. For most men, this ratio is about 15 to 1 testosterone to estrogen ratio. Although for most men, this ratio is fixed, we do know that in some men may have an abnormally high ratio of estrogen to testosterone due to excess aromatase activity. One of the main known factors of this is increased fat cells or obesity. Aromatase is primarily within fat cells, and studies have shown that aromatase conversion is higher in obese men. So, where are the estrogen receptors in the body? They appear all over in men, and blocking testosterone or blocking estrogen has very different effects. Let's look at some of the sites where estrogen has been found, and let's also look at studies that show where it's been shown to have a benefit. In the pancreas, islet cells are responsible for insulin production, and estrogen has a beneficial effect on their function. Bones are also notorious for having estrogen receptors, and men with estrogen mutations have skeletal problems with severe osteoporosis. Other men that have had their estrogen levels blocked, especially elderly men, um, frequently have osteoporosis. In terms of the cardiovascular system, there appears to be a link between a lack of estrogen and heart attack risk. From a population level, we have known for some time that women have less heart attacks than men, until menopause, at which point the rates become more similar. The drop in estrogen levels at menopause is likely part of the reason for the increased cardiovascular risk for women at that age. Several animal studies have shown that estrogen may play a role in the cardioprotective effect. In the brain, there are estrogen receptors in men, and a lack of brain estrogen receptors has been associated with increased obesity. Interestingly, some of the highest concentration of estrogen hormone levels and receptors in the male body are in the reproductive system. This is true of many male mammals and not just humans. But in human men, peripheral blood estrogens typically range from 20 to 40 picograms per milliliter in various trials. But in the semen, the average was 162, or 8 times higher than average. We can see visually estrogen receptors throughout the cells of the reproductive tract microscopically, suggesting some role. These slides that are stained for estrogen receptors light up everywhere. A lack of estrogen has been associated with infertility. This study removed the estrogen receptors in male mice, and they found that estrogen regulates the reabsorption of fluid in the head of the epididymis. Disruption of this essential function causes their sperm to enter the epididymis diluted rather than concentrated, resulting in infertility. Finally, in terms of libido, estrogen has been shown to be essential. This has been studied in several different ways. First, in castrate males, several studies have shown that estrogen supplementation alone improved libido to normal levels. Finally, two very important studies demonstrated the use of estrogen blockade in testosterone users that had deleterious effects that we're going to review later in detail. But these studies will show clearly that estrogen is important for libido and sexual function. Next, let's look at some of the benefits of aromatase inhibitors. If you look online, you may have read that there are some benefits of testosterone and uh, replacement and infertility for men on anastrozole. It's been shown to increase testosterone. What do these studies show about anastrozole? There have been a number of studies that show some benefit from anastrozole use. These studies are not in men who have been on testosterone replacement therapy. These studies were based on men who have low testosterone, not on replacement therapy. Additionally, these studies were also done on men with low testosterone that had abnormal levels of estrogen compared to their testosterone. So their testosterone to estrogen ratio was quite low. But in these men that were treated with anastrozole alone, they had significant increases in their serum testosterone, 50% in this one study. This is due to a decreased conversion of testosterone to estrogen by blocking aromatase. Interestingly, if you look at this study, the amount of estrogen levels dropped from 15 to 12. But that slight decrease from 15 to 12 was associated with a decrease in bone mineral density after only 12 months. Of note, in this study, the men were 65 years or older. Their serum testosterones were low to begin with, but increased by 50%. However, even that small difference in estrogen from 15 to 12 caused decreased bone mineral density. A separate study that looked at anastrozole use in elderly men and also was significantly associated with bone mineral density loss. There are multiple studies that have been shown that men with aromatase excess who have an unusually high testosterone to estrogen ratio may have a benefit from the use of aromatase inhibitors. A review of these articles is here. But these men had low testosterone and abnormally high testosterone to estrogen ratios of less than 10 to 1. It is important to recognize that the benefit of aromatase inhibition in these patients is very different than in those patients who are also taking testosterone. In men who are not taking testosterone, who have high aromatase levels, the higher relative level of estrogen in the body suppresses the production of luteinizing hormone in the brain because of the feedback loop within the body itself. The brain has a feedback loop for both testosterone and estrogen levels. If either is low, it will increase the production of the luteinizing hormone, and the testicles will make more testosterone, and more testosterone will get converted to estrogen. So, in these men, lowering the estrogen levels slightly told the brain that the levels were low and it ramped up LH production. These men saw up to a 50% increase of testosterone production. However, on men who are already on what we call exogenous testosterone or replacement therapy, people who are getting testosterone, they have high levels of testosterone already. Dropping the circulating estrogen levels slightly does not ramp up the brain's production of testosterone because the feedback loop is broken. The brain simply sees there's plenty of testosterone and we don't need to make any more. So, how do we know it's harmful? Well, let's look at these two very specific studies that show that using aromatase inhibitors with men on testosterone replacement therapy is associated with worse outcomes. The first study compared men on testosterone alone to men on testosterone plus misterolone. It was a small study with only 12 men in each group, but it was a double blind, randomized control trial. And even in this small population, after only a month, the group of men that were on both testosterone and the aromatase inhibitor had worse erections, worse libido, worse ejaculations, and a worse reported mental state. That's a very impressive study with such a small population. The second study was a much larger study with a total of 200 men in each group, or roughly 400 men total. In this study, they took healthy men and made them have low testosterone level by blocking their hypothalamus with a drug called goserelin. They wanted to make sure that the testosterone production by the testicles in these men was minimal, so that all the testosterone in their body was coming from what they were giving the men. They can then control specifically how much testosterone each man had. They then split into several groups. One group got anastrozole, and one group did not get anastrozole. They then had further subgroups where they gave them either no testosterone or slightly higher doses of testosterone. Unsurprisingly, the men that had no testosterone replacement and their testosterone was medically blocked were basically what we call medically castrated or had very, very low levels of testosterone. These men had increased body fat and decreased muscle growth. But the interesting finding was actually in the high testosterone replacement groups. In the men that were giving high levels of testosterone, if they were given anastrozole, they had increased levels of body fat, more so than the control group with very low levels of testosterone. Across the board, men who received anastrozole had worse sexual desire and worse libido. There did not appear to be any benefit for men on anastrozole who were taking testosterone. So, for the men out there on testosterone replacement therapy, I'm repeatedly asked, should I be monitoring my estrogen levels on testosterone? What if my estrogen levels go high? I don't want this female hormone to go up. We don't know if monitoring the estrogen level is helpful at all. The Endocrine Society does not recommend checking estrogen levels or monitoring at all for the standard patient on testosterone replacement therapy. What if I have symptoms of estrogen excess? How do I know if my estrogen level is getting too high? Again, as I said before, it appears that a moderate amount of estrogen is helpful in men. In a small portion of men, increased levels of estrogen when on testosterone therapy can lead to some side effects, including gynecomastia, or what we would call breast development. It would seem logical that putting these men on aromatase inhibitors may be effective to treat this. The results are not so clear. Some studies showed a small benefit. Other studies in prepubertal men showed a benefit of preventing breast breast size. However, in adult men, most studies showed no benefit compared to placebo. Aromatase inhibitors are not considered first line for gynecomastia at all. Comparing aromatase inhibitors to tamoxifen, a selective estrogen receptor modulator and not an aromatase inhibitor, tamoxifen was much more effective and is now recommended as the first line treatment for males developing gynecomastia on testosterone replacement therapy. To summarize everything today, estrogen is not just a female hormone. Males have estrogen receptors throughout the body, and the hormone estrogen is critical for male sexual health, libido, and erectile dysfunction. Even a slightly decreased estrogen level can be associated with sexual dysfunction and decreased libido. Raising someone's testosterone with testosterone replacement therapy does raise estrogen levels. The reason for this is the enzyme called aromatase. This enzyme converts a consistent ratio of testosterone to estrogen levels. This is a normal effect. It is likely that maintaining this ratio is important, and having a quote unquote abnormally high estrogen level based on the lab result is incorrect. The amount of estrogen that you have should depend upon the amount of testosterone you have. It's very tempting in medicine to try to get a lab results to look normal. However, treating someone with medications just to make a lab result look better can lead to unwanted consequences. That's why it's important to do studies on medications and examine the potential side effects. Until further studies can be done to help us understand these side effects of aromatase inhibitors, they should be used with caution, especially in men on testosterone replacement therapy. To date, the only studies that show a benefit for the use of aromatase inhibitors were in men with low testosterone who are not on replacement therapy. Additionally, the men had to have an abnormal testosterone to estrogen ratio. And even in those studies, there were side effects of the medications. It improved fertility, increased testosterone levels, but was associated with decreased bone mineral density. Hopefully, this information was helpful for you today. If you like this video, please click on the like button below and subscribe to our channel. Please place any questions below in the comments, and I will try to answer them. Again, Dan Resnick from Pacific Northwest Urology. Thank you.